and it is going to be a very interesting one. So, after this welcome, I hand over to Dr. Sanjeev Phatak for the citation of Dr. Bansi Sabu's achievement.
Yeah. Good evening, and thank you, Acmedix, thank you, Ajay Bhai, and your team for giving me this opportunity to not only introduce and do the citation for Bansi, but felicitation of Bansi as chairman of the IDF Southeast Asia region. It's really a big honor, not only for Bansi, but for the whole nation, especially all of us who are involved actively in the management and prevention of diabetes. I think it's a very big achievement. Of course, we wish him even greater heights in future, and I'm very sure that he's going to achieve that very soon. Today, we will honor him with a shawl, and that's why I'm here. I'm not doing it as a webinar. That's why I've come to Bansi's clinic. It's a big honor for me to honor him, and I'm not going to lose this opportunity to introduce him to this audience. I know that everyone knows Bansi as a very close friend, brother, and a very distinguished doctor. But some of the things which I would like to highlight, which will be known to most of you, but it's still very important today, that it's an immense pride and respect that we honor him as a visionary leader, pioneering diabetologist, and dedicated advocate for the diabetes care. On his appointment as the chair of the IDS Southeast Asia region, Dr. Sabu's journey is one of the relentless commitment to improving the lives of people with diabetes. As chairman of DiaCare, a diabetes care and hormone clinic in Ahmedabad, and as ex-president of Research Society of Study for Diabetes in India, he has led transformative efforts in the clinical practice, research, and public health policy. We all know this, and his academic and scientific contributions with more than 460 publications and maybe more by the time I'm talking here, and tens of thousands of citations have significantly shaped the understanding and management of diabetes in India and the world. He's very passionate for diabetes care and research. He holds key leadership as Secretary of Diabetes India, Indian Academy of Diabetes, Vice President of the Diabetes Asia Study Group, and founder of DTEC, Diabetes Care India, that is an NGO, and also as member of the advisory group of the American Diabetes Association, AEA. So it's really a great honor. He's a tireless educator, mentor, innovator, and he has been instrumental in raising the awareness about young onset type 2 diabetes, which is his thesis, I believe, and pioneering strategies in the diabetes technology as well. In addition to all this qualification, his approach has always been patient-centric, whether he is treating the patient in his clinic or whether he is delivering the lecture. He keeps his eye on the patient care overall and not just on the science. So it's a mixture of science as well as understanding the patient's psychology, which makes him one of the topmost diabetologists of our country. His leadership in the Ahmedabad Declaration and other regional collaborations reflects his ability to bridge the clinical excellence with systemic change. As he takes on this esteemed regional leadership at IDF, we recognize not only his past achievements, but also his continued dedication to advancing equitable, high-quality diabetes care across Southeast Asia. His vision, experience, and passion make him an inspiring figure in the global fight against diabetes. We obviously salute him for his exceptional services to medicine and humanity, and we stand with him in this new chapter of leadership, confident in lasting impact that he will create. So it's really a big honor. Congratulations and very well done, Dr. Bansi Sabu.
Thank you, sir. Thank
you. Today with us, we have Dr. Sunil Gupta, Dr. Archana Shada, Dr. Pratap Deshwani, and Dr. Sanjay Agrawal, who are the expert panel members for today's session. I hand it over to Dr. Banshi Sabu for his acknowledgement by different societies. Dr. Banshi.
First of all, thank you, Sanjeev Bhai. Sanjeev Bhai is like my elder brother, very, very close friend of mine. We are working in Ahmedabad since last 25 years, so we work very closely. Even our clinics are hardly 1 kilometer away, but we are very, very close friends. And most of the meetings, nationally, internationally, we have attended many times together. But nowadays, my frequency of traveling has increased so much so, and that's the reason we meet less often. So it's really great opportunity today that Sanjeev had come to my clinic and we are sitting together. I'm thanking my elder brother, Dr. Sunil Gupta, very close friend, my sister Archana, and my dear friend Pratap Jetwani, which is like my very younger brother, very, very close to me. Thank you, Empagliflozin. Thank you, Ajay Bhai. And Ajay Bhai comes always with a newer idea that, first he had come with the idea of Dapagliflozin we should introduce at a very low price. And that was his idea. At the same time, when EMPA was to be introduced, he asked me what we should do. I told that if you can come out again with a very low price, that could be a unique feature for the company. At the same time, many persons who can't afford the molecule like this, even it may be 15 and 20 rupees may be costly, but for 5 and 7 rupees will be real good price, and that will be helping many persons, particularly in tier 2 cities and some of the rural background or rural part of our country, where even less than 10 rupees really makes sense. When we don't want to push the first line therapy, sulfonylurea, which is as costly as now their DAPA and empagliflozin, probably this may be a choice of therapy for many of our diabetic patients. Today, we designed program in such a way that more than 1,000 doctors from MP, rest of Maharashtra, other than Mumbai, Gujarat, some part of MP and some part of Rajasthan and UP, who will be joining. There are 2,000 doctors who are registered for this meeting. So without wasting much time, I will first request Dr. Sanjeev Bhai, who is going to talk, and then later on Dr. Sunil Gupta. But then we will be involving all of you. First our panelists, and then if anyone have any questions, we will answer for that. We also do the IDEA Southeast Asia Chair in Diabetes Asia. I have just recently done for 2 days program of learnings from IDF that was from in Diabetes India. And to our surprise, it was a 3 days program. And every day there were 1,200 doctors who were logged in. It was around 2,000 plus doctors who were registered, but live listening for 1.5 hours to 2 hours, that was really great. And now we are doing and one more program that I have done for Southeast Asia, where even people from Bangladesh, Nepal, and some like Malaysia, Indonesia, where we could do. Now I'm doing for Diabetes Asia also. So one advantage of this COVID was, now you can reach out to the doctors who are otherwise normally not attending the meetings. They can't afford to go to the big meetings. In India, we do a lot of regional activities. Like Sunil is now next month, he is going to do a meeting for Nagpur. So I'm sure around Nagpur, 200 kilometers, many of the physicians will have to attend. Similarly, last month, Aurangabad, Archana has done. We have done recently a closing meetings. Many meetings which we keep on doing in India. But still, many parts of the world, particularly the countries like Nepal and Sri Lanka and Malaysia, Indonesia, from Southeast Asian other countries like Cambodia and Myanmar, they join this type of meeting, which is completely online, and they would like to learn more and more. And there is a lot of differences. Even Southeast Asia looks like a small region, like an Indian subcontinent, but there is a lot of regional differences, a lot of disparities in managing diabetes. And same the Diabetes Asia, where 54 countries, which includes from China to Middle East or North Africa, Egypt country, and Far East to Taiwan and Japan and all these countries, which we are going to do again 2 days program on 27 and 28th May. And 26th, we had kept an annual general body meeting of Diabetes Asia. So those who are members of DSG, Diabetes Asia, please join for all 3 days. It is 1.5 hour program every day. Just to connect the people, we can learn something from experts who are already speaking for that. If you want to know something more, you can ask the question one-to-one. but it's also a platform for a lot of networking. You will know many people through this online platform too. So with this, today I hand over now session to Dr. Sanjeev Phatak, who is a eminent diabetologist of City of Ahmedabad. He is currently became a director of Diabetes and Metabolic Center, Metabolic Clinic in a one multi-specialty hospital of more than 400 bedded hospital, very big, large, big hospital. And he's also having a big center of diabetes, which is spread over more than 5,000 square feet. A lot of persons are working with having more than 60 to 70 patients coming to this clinic. So with this introduction, I first invite Dr. Sanjeev Phatak for his talk, and later on, we have Dr. Sunil Gupta, and then we will have a panel discussion. Oh, first is Dr.
Yes,
okay,
Sunil is going to speak.
So you please introduce
Yes.
Sunil. Sorry. Sunil, you will be presenting slides from your side? Yes, he will be presenting.
All right.
So you introduce Sunil.
So let's start the session now. We have with us Dr. Sunil Gupta, again a very well-known diabetologist from our country, from Nagpur. He's expert not only in the field of diabetes, but super expert in the field of diabetes and pregnancy, which is his passion. But today we are going to listen from him the place of Empagliflozin in the modern diabetes. It's over to you, Dr. Sunil. You will be presenting the slides from your end, I believe. So it's all yours.
Hope my slides are visible.
Yes, sir. Yes.
They are full screen.
Not yet.
No, now it is done. Yes.
It's done now. Yeah. Thank you. So thank you very much, Dr. Shah. Of course, thank you, Bansi Bhai, Sanjeev, Archana, Pratap Bhai. All of us actually are there at various academic platforms as a family, and always cherish these moments. Now, my job here is to just give you a brief introduction about the role of Empagliflozin. I know everyone must have seen these slides earlier also, because of a lot of earlier CMEs and webinars last almost 10 years or so. It is just going to be little revision of the whole knowledge of what we have already learned. And this particular session has been sponsored by Dr. Shah and their company. So it is going to be the slides have been given to us by them, but the thought process is going to be absolutely our own. And we will be talking more into the science. So place of Empagliflozin in modern diabetes management. The non-communicable disease kill almost 41 million people each year, which is equivalent to almost 74% of all deaths globally. Each year, more than 15 million people die from non-communicable diseases between the age of 30 and 70. And 85% of these are premature deaths occur in low and middle income country. Cardiovascular disease account for most of the NCDs, or almost 18 million people annually, followed by cancers and respiratory diseases and diabetes per se, 1.5 million. These four groups of disease account for almost 80% of premature NCDs. Now, one thing should be very important, that most of the deaths which are not directly being related to diabetes, but might be related indirectly, because many of the deaths which are being actually coined or has been labeled as a cardiovascular death have a background of diabetes. So whenever we try to treat a case of diabetes, we are not supposed to be glucocentric, and we have to have a precise approach involving overall pleiotropic benefit of a molecule when you use, so that you have a holistic approach. You have to supposed to see that whatever the medicine you use for reducing blood glucose should not only be having glucose lowering efficacy, but also should have safety as well as associated benefits, which could be on the heart failure. You should have a benefit on the atherosclerotic cardiovascular disease. It should be beneficial for patients with dyslipidemia, cardiomyopathy, dysfunctional fat in the heart and myocardium and other places. insulin resistance, beta cell dysfunction. The only thing is that we should also be thinking of hypoglycemia. So the drug should achieve a good glycemic control, should be beneficial for achieving good glycemic control without increasing risk of hypoglycemia, without increasing risk of obesity, giving an additional advantages for the renal, heart failure, cardiovascular disease as a whole, as well as now you have data also coming up for the non-alcoholic fatty liver disease, that is MASH. So all these benefit if your molecule gives to a patient with type 2 diabetes, that can be called as the best treatment or best prescription. And why do you need to do this? Why do we need to have a holistic cardiorenal metabolic risk reduction, CRM risk reduction in patient with type 2 diabetes, especially more so for our country? 1 out of 9 Indian patients have type 2 diabetes, and their management need very aggressive approach. And if you just see the ABC control, A1C, blood pressure, and C is LDL cholesterol. If you just try to see this composite target of Indian population, 80% of them have still not achieved this. So we have to have a holistic approach, because 1 out of the 3 Indian adults have with type 2 diabetes has chronic kidney disease. 1 of 10 Indians have rapid decrease in the eGFR. 1 out of 3, that is almost 30% or 33%, have cardiovascular disease globally, and every second patient may have a left ventricular diastolic dysfunction. So, and everyone knows that it is the dysfunctional fat which is responsible for the insulin resistance. And there is a typical characteristic of a person with type 2 diabetes in India. Why? Because our population, we have the patient diagnosed with type 2 diabetes. They are diagnosed at a younger age, almost 10 years younger than the Caucasians. They have less generalized obesity, but they have more visceral obesity. So we are being called as thin fat Indians, because we have more central obesity. And this visceral obesity, everyone knows, is more atherogenic than this generalized obesity. So we have high central obesity, higher the more insulin resistance, greater cardiovascular metabolic risk. And this is a diagram on my right, which has just shown that if you just have a comparison between the Indian versus the United Kingdom white, so white population versus Indian population, our diagnosis is almost 10 years younger. We have little generalized obesity is less versus Caucasians. Mid-arm circumference also little less, but we have waist hip ratio which is high, so we have central obesity, and we have higher amount of fat, almost 30%, and higher amount of insulin resistance. That is what is seen, as well as subscapularis fat, and is also higher. So we have higher central obesity, higher insulin resistance, higher visceral fat, and we are being diagnosed early, and that is why it becomes an additional challenge to all of us to focus on all other aspects of control of blood glucose, rather than just becoming glucocentric. And now most of the guidelines, whether it is ADA guidelines, whether it's ACE guidelines, IDF guidelines, RSSDI guidelines, everyone now focuses, they try to assess the ASCVD risk in a patient with type 2 diabetes. So atherosclerotic cardiovascular risk profile has to be assessed in patients who are coming to you, even if they don't have any event. So they might be, some of them may have some event, some of them may have just risk factors. So if you have any ASCVD risk or the event, or at the high risk of event, such patients, the first drug of choice should be GLP-1 analog, if they have because they have shown the CVD benefit, as well as the SGLT2 inhibitors have clearly shown that it is helpful for the patient who have associated cardiovascular disease, or who have a cardiovascular risk profile. And if your goals is not achieved, then you should certainly, if SGLT2 inhibitors and maybe metformin is already on, if these patients are not responding well to this combination, then you can go for GLP-1 analog. In addition, and then of course, still not achieve the goal, then you can go for third and fourth line treatment with maybe sulfonylurea and other drugs. But what is more important is the message is, anyone coming to you with ASCVD event or have the higher risk of cardiovascular disease should be subjected primarily by SGLT2 inhibitors or GLP-1 analog, so that they are being protected. Even in non-diabetics patient, even if they're not diabetic, SGLT2 inhibitors have been advocated. But here we are talking about type 2 diabetes. This becomes a drug of choice, and the very first drug of choice. If you talk about the European guidelines, they say SGLT2 inhibitors should be even before metformin. Here we say metformin as a baseline therapy, and then we go. But I feel now with the reduced ejection fraction, or maybe heart failure with preserved ejection fraction. So HEF-REF and HEF-PEF, both of these, if you combine together, almost every second patient with type 2 diabetes may come to a simple diastolic dysfunction. So such patient, again, SGLT2 inhibitors have proven significant benefit, and they are supposed to be the drug of choice. So all patients, now cardiologists are writing more SGLT2 inhibitors than diabetologists because of this, because they are also covering the non-diabetic population. Similarly, if you have chronic kidney disease, eGFR less than 60, or anyone even with proteinuria, then SGLT2 inhibitors have shown a clear benefit, and it should be started if the eGFR is more than 20, and it should be continued until initiation of dialysis or transplantation. And SGLT2 glucose lowering efficacy is reduced once the eGFR. So may not be necessarily for the glucose lowering efficacy after the eGFR goes below 45, but for the renal, for the progression of the disease to be slowed down, or maybe if there is rapid fall in the eGFR, that also being slowed down with the use of SGLT2 inhibitors, along with if they are being used with ACE or ARBs. GLP-1 analog has also shown to have its benefit. And of course, weight management also, those who are obese people, you should be focusing on drug which should not increase, like sulfonylurea will increase weight, pioglitazone will increase weight, insulin will increase weight. But these are the drugs where metformin, along with the combination of SGLT2 inhibitors, is one of the good choice, where metformin is weight neutral. To some extent, you can have weight reduction, as well as SGLT2 inhibitors, though are not being promoted as a weight losing drug, but certainly have little weight loss, and an obese patient at least will not have a weight gain once you achieve good glycemic control. And that is why that is being recommended. So here are some data. You have a greater HbA1c reduction when you use empagliflozin versus the sitagliptin, and they have shown significant reduction with 25 milligram of empagliflozin versus 100 milligram of sitagliptin, and that was statistically significant, 0.05 p-value, whether it is HbA1c 8 or 9 or baseline 10. So higher is the baseline, higher is going to be the difference. Empagliflozin also improves the insulin sensitivity in patient with high insulin resistance, and they have done HOMA-IR insulin resistant model, and they have seen fasting insulin level, as well as they have also shown reduction in the cholesterol. Even beta cell function have shown to be improved. They have measured fasting C-peptide by using the hyperglycemic clamp studies, and they have seen beta cell function and beta cell glucose sensitivity, and they have again seen from day 2 onwards to even day 14, and they have shown classical improvement in the fasting blood glucose, and then the C-peptide have secretion. That means C-peptide actually denotes the insulin secretion from the beta cells, so it has improved, as well as the beta cell function has improved, as well as beta cell sensitivity to the glucose also improved. EMPA also facilitate the blood pressure goal in patients who have resistant hypertension. So systolic blood pressure, diastolic blood pressure seem to be 4.5, 1.7, which was again statistically significant. And even the goal, how many of them? Almost 37. So every third patient have achieved their targets of the blood pressure in the study. EMPA also reduces the risk of first and the recurrent cardiovascular event in patients with type 2 diabetes. Everyone is aware of this EMPA-REG outcome trial, and this is the only drug which has shown even reduction in the death of the due to migraine infarction. And so almost 21% reduction in the risk of migraine infarction event, when you compare empagliflozin versus placebo. They've also shown the benefit on 3P MACE, microinfarction, and the microinfarction or coronary revascularization. And this risk reduction is from almost 20 to 22%. As well as renal benefit is concerned, again from the EMPA-REC outcome, if you see here, even up to the eGFR of less than 45 or even it is 90. So irrespective of the eGFR, whether it's more than 90 or maybe it is less than 45, the benefit is seen to be almost continued. And even there is also improvement in the earlier we used to teach even Dr. Sanjeev and Bansi and Archana and Pratap Bhai, everyone will agree on the point that earlier we used to say microalbuminuria is a stage where the renal diabetic nephropathy is reversible. Once it touches the macroalbuminuria, it is not reversible. But SGLT2 inhibitors have disproved this notion, what we have learned almost 10-15 years from now. Now we say that if you use SGLT2 inhibitors or GLP-1 analog, it is likely that the macroalbuminuria will also be reduced or will come back to microalbuminuria, or microalbuminuria will come back to normal when you use SGLT2 inhibitors like empagliflozin here. EMPA has also shown consistent improvement in the kidney disease outcome in patients with diabetes and kidney disease. So this is again, this is the progression to the disease has seemed to be reduced here, and the progression to the and the 45% risk reduction in the progression to the kidney disease and kidney failure, almost 24%. So if you, this is possibly the last slide, if you see the holistic approach of cardiorenal metabolic care in patient with type 2 diabetes, empagliflozin has shown in patient with early T2DM, initiation of EMPA can be relevant to have not only effective HbA1c control, not only consistent control, low risk of hypoglycemia, no additional weight gain if it is not being used with insulin or with sulfonylureas, improves the time in range, so in glycemic variability is also improved, weight loss, including reduction in the diastolic dysfunctional ectopic fat, which is atherogenic and which increases insulin resistance, improvement in the insulin sensitivity and beta cell function, so beta cell health is improved, ectopic fat is improved, glucose has been controlled, hypoglycemia has been reduced, glycemic variability is taken care. There's definite benefit on the blood pressure reduction, reduction in the major cardiovascular event, cardiovascular death, heart failure outcome or hospitalization for heart failure, as well as the composite death has also and cardiac death has also been found to be beneficial. Improvement in the kidney outcome has also be seen. So it is a molecule which has given benefit to all these cardiorenal and metabolic parameters, as well as giving a benefit to the beta cell health. So it optimizes the clinical consideration of risk benefit for each anti-diabetic therapy in principle of the individualized approach for every patient. I feel with this I stop here because we should have enough time for discussion with our panelists. Over to Dr. Sanjeev Pathak and Bansi Bhai for further proceedings. Thank you very much for patience listening.
Thank you, Sunil, for highlighting the importance of the holistic management of type 2 diabetes. And now we know that molecules like SGLT2 inhibitors, GLP-1 analogs, along with metformin, not only are beneficial in controlling the glucose, but also in reducing the complications of diabetes, which all of us have been trying to target for so many years. But unfortunately, we did not have any molecule or any class of the agents that were really able to address that. So after a very elegant talk by Dr. Sunil, I'll be talking about how cardiovascular outcomes are influenced by the empagliflozin. I'll just try to present my... Yes. Slides visible. Okay. I believe it is in the full screen mode now, slideshow mode.
Yes.
Okay. So if you try to contextualize the cardiovascular risk in presence of the ASCVD compared to the heart failure risk, we know that diabetic patients, if you look at the ASCVD risk, yes, ASCVD risk, the diabetic patients are either high risk or very high risk as far as the ASCVD event rate, that is myocardial infarction or ischemic stroke, is concerned. A person will be high risk if he does not have any event or does not have many risk factors, but becomes very high risk if he already has an event or multiple risk factors, where our LDL goal also becomes a little quite lower. But at that stage also, the overall risk of mortality is between 1% to 7%. Compared to that, if patient has developed heart failure, he is at a very significantly increased risk of mortality, starting from 10% to 40%, depending upon the status of his LV function and status of his therapy, whether the patient is responding to the therapy or not, how frequently he is needing the hospitalization and all that. Which means that if the patient is taking multiple guideline-based therapy for heart failure and still not responding, his risk of dying in next 12 months becomes or remains very, very high compared to the ASCVD event rate, where you can do a lot of other things, including intervention, to save the patient's life. And that's why heart failure is much more important than a cardiovascular event of an ischemic origin. And that's why these days we have been focusing on preventing the heart failure hospitalization and mortality related to heart failure. Not that the ASCVD events are not important, but heart failure probably assumes even greater importance. Now, what are the reasons which make a diabetes patient susceptible to heart failure? Independent of coronary artery disease or independent of hypertension, there are factors in diabetes patients which make them vulnerable for development of heart failure. First of all, hyperglycemia leads to mitochondrial dysfunction. It leads to increased oxidative stress, abnormal cardiac myocyte calcium homeostasis. In addition to that, there may be some genetic factors, advanced glycation end products, autonomic dysfunction, microangiopathy, and subclinical myocardial necrosis. We know that diabetes patients as well as hypertension patients, because hypertension is a comorbidity that is associated with diabetes in more than 60-70% of type 2 diabetes patients. So there is RAS activation. There is increased activity of the sodium hydrogen exchangers NHE1 as well as NHE3. And then there are certain metabolic derangements in the cardiac myocytes, lipid accumulation in the cardiac myocytes, lipotoxicity, lipoapoptosis, and the effect of adipokines. All these make a diabetes patient much more susceptible to the heart failure incidence as well as mortality. And that's why we need to prevent heart failure right from the word go, along with good glucose control. Not only the systolic function that is affected, the diastolic dysfunction is also very, very commonly seen in people with diabetes. The meta-analysis of 27 echocardiography-based studies have shown that about 46% of the type 2 diabetic patients have left ventricular diastolic dysfunction, and left ventricular diastolic dysfunction is also responsible for a significant increase in the morbidity as well as mortality. Never before EMPA-REG, we realized that diabetes management can actually reduce the cardiovascular event rate also. The previous studies, DCCT with intensive glucose control using insulin in type 1 showed reduction in the microvascular complications. UKPDS also was not statistically significant in reducing the cardiovascular event rate. And advanced ACCORD and veteran affairs trial actually showed other way around, that very intensive control or tight control can actually increase the cardiovascular risk. So EMPA-REG came as a real surprise. Initially, people thought that the results are too good to believe, but then the subsequent analysis and the full study literature clearly showed the advantage of this molecule empagliflozin in reducing the cardiovascular risk, the cardiovascular death, and overall death in type 2 diabetic patients. And this was
surprisingly, regardless of the glucose control. So in spite of glycemic equipoise in both the groups, empagliflozin arm showed a significant 38% relative risk reduction compared to placebo, hazard ratio 0.62, very significant p-value of less than 0.001, which means that empagliflozin plus standard of care reduced the cardiovascular risk by about 38% in the EMPIREX study. The Asian sub-analysis of this study showed even better numbers, 56% relative risk reduction in the Asian patients who were enrolled in this trial. In an Asian diabetic patient, if you are using empagliflozin, you are reducing his cardiovascular death or cardiovascular event rate by about 56%, which is mammoth. Not only the cardiovascular death or heart failure hospitalization were reduced in patients with reduced ejection fraction, this benefit was seen regardless of the ejection fraction. You can see from the Emperor reduced trial, which was a heart failure trial in patients with LV ejection fraction of less than 40, where empagliflozin showed relative risk reduction of 25% compared to placebo. The number needed to treat 19 for 60 months. But even in patients with mid-range or mildly reduced ejection fraction, HF, MR, EF, where ejection fraction was 41 to 49%, you can see significant reduction of 29%, again statistically significant, number needed to treat 21 for 26 months. And even in the Emperor preserved, where the ejection fraction was more than 50%, there also significant benefit was seen with p-value of 0.024, that is below 0.05. Of course, the number needed to treat is higher here, 42 for 26 months. Understandably so, because these are lower risk patients compared to the high risk patients who have reduced ejection fraction. So for that matter, any molecule, if you are using it in high risk patients, will give more benefit compared to its benefit in the low risk patients. And that was consistent in this trial. In Emperor reduced, there was much more benefit. In Emperor preserved, there was less benefit compared to reduced, but still statistically significant benefit was there, even in patients with ejection fraction of more than 50%. So regardless of LV function, empagliflozin reduced the cardiovascular event rate, cardiovascular death rate, as well as the heart failure hospitalization rate and the heart failure mortality also. Now, albuminuria, which we were talking about, Dr. Sunil very well explained that previously we never believed that from albuminuria stage you can become normoalbuminuric. You can at most come down to microalbuminuria or 30 to 300. But now with SGLT2 inhibitors and agents like finerenone, we now have evidence that these drugs also reduce the renal disease progression. But here in patients with albuminuria more than 300, between 30 to 300, what we call microalbuminuria, now that term is no longer used, or in patients with normoalbuminuria, that means UACR of less than 30, you can see the hazard ratio is to the left of the median, which means regardless of the albuminuria levels, the Emperor pooled data shows that empagliflozin reduces the risk of cardiovascular death or heart failure. We know that with albuminuria, the risk of heart failure and cardiovascular event rate is much higher compared to patients without albuminuria. But here it has been clearly shown by empagliflozin study that regardless of that, empagliflozin reduces the CV risk, CV death, and hospitalization for heart failure. So based upon these studies, now we know that empagliflozin has class 1 level A indication in patients with heart failure less than ejection fraction 40%. Mildly reduced ejection fraction, again class 1, level A evidence, ESC 2023. And heart failure with preserved ejection fraction also, level 1 evidence, level A, ESC 2023. Now there is a new category, that is heart failure with improved whose heart failure was with reduced ejection fraction of less than 40%, if they improve by 10 points from the baseline LVEF, then it is known as heart failure with improved ejection fraction. And the guidelines are now that the GDMT, including SGLT2 inhibitors, should be continued in patients with heart failure with improved ejection fraction, regardless whether they have improved and how much they have improved, whether it has improved even up to the normal range also. Still, you need to continue empagliflozin or the SGLT2 inhibitors. Now, the biggest question comes these days is which one to choose first, a GLP-1 or empagliflozin or SGLT2 inhibitor. Well, actually, there is no competition between these two molecules. Both actually complement each other and both should be combined in a given patient for the best cardiovascular outcomes. But if you like to compare, then obviously for patients with heart failure or cardiovascular death, empagliflozin has a clear edge over GLP-1 analog. This is GLP-1 analog. This is empagliflozin. The hazard ratio is 0.77. That means 23% benefit compared to GLP-1 analogs. GLP-1 analogs are also associated with benefit. We now know from the SOUL study also that even oral semaglutide has cardiovascular as well as heart failure benefit. But empagliflozin, the benefit is definitely much more. This is not a head-to-head trial comparison, but the analysis from the different studies, especially EMPRISE, have shown a benefit in favor of empagliflozin compared to GLP-1. From atherosclerotic event, probably both are same, EMPA and GLP, but from heart failure, obviously, and for heart failure and CV death, empagliflozin has a clear-cut edge. With this, I will stop here because we'll have a very healthy discussion because so many experts are here. We have Dr. Pratap Jetwani, we have Dr. Archana Sharda. I think we will be missing Dr. Sanjay Agrawal, who is not there, not yet joined. So I'll invite Dr. Bansi again, our guest of honor, and we can have some very important discussion questions here so that some of the concepts can be clarified. Dr. Bansi?
Yes, Sanjeev, I am here. You can join from here only. I think that will be better. So both we can.
Okay. So I think I'll stop sharing from here. And okay, myself and Bansi will be together in a single room.
Yes. So first of all,
you can start.
two wonderful talk by Dr. Sunil Gupta and Dr. Sanjeev Pathak. We don't have Dr. Sanjay Agarwal, but we have Archana and Pratap along with Dr. Sunil Gupta and Dr. Sanjeev Pathak. For this meeting, there were 1,800 doctors who were registered from, as I told you, around from 4 states. But at present, we have 620. I just asked the AV guy that how many doctors are live at present. So first question, which is very commonly asked by physicians. And this I said, first I will ask the Archana and then Pratap, but everyone can give the answer for the same. They're asking that after introduction of EMPA, do you think there is any strong evidence which shows that EMPA should be used instead of DAPA? Because that is creating so much confusion. And the same will go when with a combination of LINA and CETA instead of which I should use. And then again, whether with the CETA with DAPA or with the CETA with EMPA or whether it is a LINA with DAPA or LINA with EMPA. So a lot of this discussion is going on. Many doctors have asked the similar questions in a different way. So first, let me start with Dr. Archana.
Thank you. Thank you for having me here on this panel. And both the talks were wonderful, Dr. Gupta and Dr. I think you started with the most difficult question. I thought that would come at the end.
Well, you know, maximum questions are coming on that.
Coming like that. True, true. And people do ask that. And I think as far as evidence is concerned, except for established ASCVD, where EMPA has shown some edge over dapagliflozin, I don't see in our own observations in glycemic control and microalbuminuria, the renal benefits, all these benefits, clinically, I found it is similar It is a class effect and very much similar. The edge, which
If you are given a choice that in Sita with DAPA or Sita with EMPA, or versus Lina with DAPA and Lina with.
So between Sita and Lina, what my observation has been, other than the studies, which everyone knows the outcomes, is Sita, we get a better glycemic control, but tolerance to Lina is better. So between the two, I have found it more effective, but better tolerated is Lina. So depending on my patient, depending on their renal function, how senior they are, what other drugs they are having, and that stage, the choice happens there between these two. So,
Pratap, do you want to add anything?
No, I don't think there is any advantage of one over other. Although if we go by trial evidence, then EMPA has got trials which are done in a wide range of CKD patients and in established CVD. At the same time, if we want to treat a patient with multiple CVD specters, then DAPA has got a better evidence from trial. But otherwise, I will say both are equivalent. That is anyone's choice, whatever they want to start with. And I personally feel EMPA plus Lina, that has got a more robust evidence to support its combination therapy. It is available globally also. So that is the only reason why now people they are coming out with this combination. Otherwise, anything you can take any kind of dosa, be it a rava dosa, masala dosa, or what kind of dosa. So any gliflozin, I think, not Remo, but Kana, DAPA, EMPA, all three they are having cardiovascular benefit.
So, Dr. Sunil, if I ask you with the EMPA and DAPA which had come, and with Lina and Sita, will Vilda and teneligliptin is completely out, but with vildagliptin will stay in the market? Do you think still there is a role of using vildagliptin when the Sita and Lina is available in different combination also, or at the same time they are as cost effective as vildagliptin? So that's a question. And then second is there is no role there. I don't think now anybody is using Remo, but tomorrow, suppose one more, we know that SGLT2, which has also been there, it was there, Kena, and there was a lot of evidence for that too. Suppose some company comes with that Kena also. So do you think there will be any role for Kena in current market situation? I mean, these all are very difficult questions, but a lot of people are asking, and these are very commonly asked questions. We have Dr. Sanjay Agarwal. He is traveling and he is traveling to Boston. So I'm sorry, Sanjay, I'm just telling everyone that you are going to Boston, but this is what I know.
Good evening to everybody.
good evening, sir.
Good morning.
Hi, good morning. No, I'm still in India.
Oh, yes. No, just British Airways called me that Sanjay is traveling today, in first class. So. So, Sanjay, I was asking Sunil, so let Sunil to answer, and then I will ask the same question to Sunil.
Surely.
I feel as far as the Sita versus Lina versus Vilda is concerned, everyone knows that Vilda does not have any cardiovascular outcome trial, but whatever we have is more of a real world evidence and a very small trial which was not very well accepted across. But then yeah, so that's one thing. And second is Vilda, if suppose you want to give, my personal experience, if you ask me, if you want to have a good efficacy, you have to give it twice a day. And if you're going even 100 milligram OD, I was not too much happy with that particular molecule. So, but twice a day when you give, it has good 90, more than 90%.
So the future of Vilda is not, I mean,
so,
you don't think there will be any place for Vilda now?
Yeah, but nevertheless, when it comes to Sita and Lina, I'll have little edge of Lina over Sita because of the reason of renal issues that it can be used to with you can write the drug and forget about it, and you can continue for years together, and you don't need to be too much bothering about the renal impairment, especially those who are coming to you with diabetic nephropathy or early stages, incipient diabetic nephropathy, just proteinuria over diabetic nephropathy, and you are expected that this patient sometimes doesn't come back to you for 2 years, 3 years. So even if there is some deterioration, you don't need to worry about it when you compare it with sitagliptin. So that way, Lina has the upper hand.
So Sunil, answer for the gliptin overall, because they are more safe and more tolerant compared to that. But Sanjay, if you see the evidence-wise, and now we are going to have GLP-1. Already oral is there. I'm sure in future there will be many more oral will come. Now we are going to have, already we have one molecule of GLP-1, which is once in a day off patented, and there will be once in a week off patented GLP-1 is also going to be there,
Yes.
which has got a huge weight reduction benefit, cardiovascular outcome trial of Lira is already there, semaglutide is there with a very high potency of reduction of HbA1c along with this. So what do you think about the future of DPP-4 overall? I know that, yes, there will be some role in elderly people, some role will be there because it is more safe and easily tolerable. So do you think that in future when we are going to have a off-patented oral GLP-1, which is more CV benefit, more robust reduction in glycemic status overall, where do you think that future of DPP-4?
That's a great question, Bansi. I feel that today there is role for every anti-diabetic agent. Just because you're getting a newer agent, it doesn't mean that the older agents are going to go out of use. You still have sulfonylureas that we use, and people had written it off to say that sulfonylureas are not going to have any place. But we still in India, if you see, you get the best A1C reduction, you get the best glycemic drop with sulfonylureas. Also, if you look at all the global guidelines, you don't see them on top, but in India it's probably the number one seller. Similarly, I don't think that GLP-1 is going to be a universally used molecule for everybody. I think you need to have specific indications where GLP-1 will be used, but in terms of tolerability, in terms of combination with other agents, I think DPP-4 will still continue to exist and probably widely used. GLP-1 will come in probably a specific let's say for obese people. These would be probably more specific indications where GLP-1 will score, but it will all boil down also to the cost factor, because we are a very cost sort of conscious society. And whatever, whenever the introduction does happen, the DPP-4 molecules will always be cheaper than GLP-1 molecules, as I can read as of now. So in terms of, in terms of, penetration countrywide in the deeper parts of the society, confidence of doctors to use a molecule which they can handle, and, patients will having minimal side effects in tolerability. I think, doctors are going to prefer DPP-4. And I think even GLP-1 will have its own place. And, it's not that we're not going to use GLP-1. But I think in wider adoption, perhaps, DPP-4 will continue to be used as much as we use metformin or sulfonylurea. And I think the combinations give you a great A1C reduction safely, and if you use judiciously with minimal hypoglycemia. And more important also, the weight effect, it's a weight neutral drug.
That's right. So with Sanjeev bhai, we now have been introduced in India even once in a week DPP. Recently in Diabetes India, and then in DTEC also 2 molecules have been already introduced in India for once in a week DPP-4 inhibitor. Do you think where they will be role? Sorry, today our talk is on related to SGLT2, but as we started with gliptin, there are a few questions on that. So I'm asking, and then we will again go back on SGLT2. So Sanjeev bhai, where you think that once in a week DPP-4 can be used in our clinical practice?
I think, Bansi, I believe there is no role of once in a week oral therapy, because our patients are going to need metformin, our patients are going to need SGLT2. So these drugs will always be required. So other drugs to be taken daily and this drug to be taken once in a week will confuse the situation. So I don't believe that once in a week gliptin is a very good idea. MSD also had this gliptin, but they gave up the idea probably because of this reason, because I don't think at present there is any need, because if you want to give any other molecule also, you can easily combine with any of the gliptins, maybe Lina or Sita, rather than giving once in a week that tralogliptin and then metformin separately and SGLT2 separately. Our is a combination market where we have very good combinations of SGLT2, metformin and DPP-4. I think the way forward is that, and not once a week.
So I agree with you, but there may be some patients who are metformin intolerant, elderly patient. You just wanted to give them a once in a week, like a mild hyperglycemia with a 7.5 HbA1c, and you wanted to give one tablet in a week along with vitamin D. So that's just a possibility, but definitely a small number of people, you can find the right persons to whom you would like to give once in a week DPP-4. But I'm sure in near future we will understand more about the real ones. We will have more real world evidence. The other question which is coming with SGLT2 in CKD, till what EGFR will you continue or will you start? There are two different things. One is, like, suppose already with below 20 EGFR, will you start SGLT2 either of DAPA or either of EMPA? Or suppose someone to whom you have started already at 25 or 30, till what EGFR you will continue as per approval or in real clinical evidence or in your real clinical practice? Sanjeev bhai, you can start.
Okay. So the guidelines are you can continue till the end-stage renal disease or up to the stage of dialysis, right? If the patient is already on the drug, you can continue. But starting below EGFR 20 is not recommended right now, though we have seen now nephrologists allowing us to initiate even at the EGFR of 18 or 19. But yes, it is off-label. So we should initiate it only when GFR is more than 20. But we can definitely continue if the patient is already on SGLT2. If his GFR drops to even 15, he is not needing dialysis. And if there are no other contraindications, you can continue.
But the glycemic control benefit may go away.
Yes.
But we know that if you are already started with a molecule, it can be continued till late stage or end stage, you can say the CKD status. So what is harm in starting a patient whose EGFR is less than 20? We know that we are not starting here for the control of sugar, but for other benefits, whether it will have, we don't have at present evidence, but off level, do you think?
Yes.
Sorry, Sanjay, you
Yes,
want to...
Sorry, I didn't know it was okay. I can answer that for you. So number one, if you're looking at renal benefits, below sort of, GFR of 20, it's not of any value because you don't have functioning nephrons. So you don't get any much benefit in terms of, am I audible?
Yes, we are.
Okay. So because you don't have functioning nephrons, you don't get the renal benefits below the age of 20. So you may give it to ESRD, but you're not going to derive any benefit in terms of slowing down the progression to kidney disease because the patient is already at the end of the road and he's not
but
really
Sanjay, not for the kidney protection.
But what you will benefit from...
No, Sanjay, my point is here not for the kidney
protection. I'm just coming to that.
Yes.
What I'm talking is the benefits will be in hemodynamic benefits. So whether you want to look at, patients with heart failure and other hemodynamic benefits, then these are the patients who will benefit even at low GFR. So, in terms of reduction of heart failure, hospitalizations.
That is the point, because all CKD patients are at, high stage of developing heart failure and the problem of that, because it's a combination of syndrome. Like, what's a person with CKD have more risk of developing heart failure too. So will it give that benefit?
Yeah, I mean, the hemodynamic benefits continue to be present because the action is not through the kidney in that case. It's more of different, neurohormone mechanisms that you tend to get. So I think the benefit for heart failure continues to exist even at low GFR, and I would continue to use it out there.
So now to Archana, we know that, type 1 diabetic patients also more often to develop the diabetic nephropathy. We don't have at present an official indication of using SGLT2 off-label. Definitely, I'm talking of diabetic nephropathy. We have SGLT2 can be used in type 1, but mainly with the persons who are become obese and overweight. The one reason is that if you use SGLT2 here for the protection of or further progression to halt CKD status for these patients of diabetic nephropathy, one side their basal insulin requirement goes significantly down and they may develop euglycemic diabetic ketoacidosis. That may be one of the reasons why it is not tried. But there is no other reason why it should not be given. So do you use or would you like to use these patients a benefit of SGLT2? Similarly, Finranon we started using now, even there is no evidence for using it because there is no randomized control trial, but there is no reason for not to use for the patient with type 1 diabetes with diabetic nephropathy, but still it is off-label. But would you like to use SGLT2, who is very regular patient to you? And you can definitely see that their basal insulin requirement is not going very low, below 0.2 unit per kg, and they may not develop euglycemic diabetic ketosis. Would you like to use or
Yes.
not? I mean,
So,
maybe definitely
definitely.
off-label.
So SGLT2 inhibitors we have actually used off-label in people with type 1 diabetes. And as you said, the selection criteria is very specific, and it has to be people who are very well aware of their diabetes, monitoring very well. They are fully conscious of all the possible ketosis, what that can happen, and infection that can happen. And they are very well versed on how to manage that, and they will report immediately. So we have used it in quite a few people with very good results, but it is off-label, so we don't really talk about it. Fineron, no, I have not thought about it, but I mean, as you said, there's no reason not to.
But
And
these are the two thoughts
but
for our
even
paper.
the dual GLP, dual agonist also, these is another thing which is now in type 1, especially with obese type 1s. That is something because of insulin sensitivity.
I have 1 or 2 patients where I had used GLP, but
Mm.
Findenon I had used quite a good for a patient with type 1.
Definitely.
And definitely SGLT2, but less number of patients.
Yes.
Pratap and Sunil bhai, you must have used a lot of patients with empagliflozin. Do you find there is a difference of genitourinary infection of using DAPA versus EMPA? Because recently people are talking that EMPA will have less. Do you think it is possible? Because it depends directly on excretion of glucose. So do you think that EMPA will have less? And there is one more question, that DAPA is available in India with the 2 salts. One is salt which is used by originally Forsica. The other companies, few companies are using other salt also. The companies who are using the original salt, they claim that they have less genitourinary infection and they found to be more effective in glucose control. So these 2 questions to both of you. Do you have any idea of that EMPA will have less, and difference between 2 different salt of DAPA in our real clinical practice?
I don't think there is any difference.
Yeah, I also
as far as genital. Yeah.
So, I mean, we don't have at present any evidence, but it can be a good real world evidence. And some of the patients to whom you can think of even crossover also, changing it over. If you find that, DAPA is causing, just for a real world evidence can be produced for media also on this.
May I ask one question to all of you? So we are always talking about EGFR cutoff for using SGLT2, that 20, 25. So what is the upper EGFR where you will prefer to use? So people now, because generally physicians feel that when the EGFR goes below 60, then and then we have to think of SGLT2 for renal benefit.
Why you can't? Is it an anti-diabetic agent? There is no reason.
So that's why even in EGFR between 60 to 90, there is evidence that it provides renal benefit.
More than 90,
so
110, whatever the EGFR. I don't know.
So that is what we have to clarify, that is, you can use it across the spectrum up to 20. It is not that above 50 that it will not provide benefit.
But make sure that if you are seeing the urine albumin creatinine ratio which is higher, start using it. Better is you start like sartan with SGLT2 and with Findenon. All 3 will work because all of them are going to halt the progression of CKD status. So, Dr. Sunil, my question is now, suppose patient EGFR is decreasing and now we have the data with flow, like with the semaglutide, the GLP-1 usage will be there. Do you think that now this is the time that you will stop all these patients on a gliptin, and would you like to put them on a GLP-1? Because that benefit of GLP-1 is not dependent on the weight reduction. It is not dependent on a glycemic control. The benefit was independent of that, the flow. Yes, there is no direct cardiovascular mortality was not decreased, but there is a definitely benefit of CV benefit was then, but not directly all-cause mortality was decreased. So do you think that this is recommended, or a time will come that even all nephrologists and all diabetologists will put the patients whose EGFR once it starts decreasing below 45 or below 60, instead of putting them on a continue on a DPP4, because we don't have that evidence except that Lina and Sita with a reduced dose and Lina with the same dose, you can use as an anti-diabetic agents. The benefit are not as we have with this GLP-1. So will you say or recommend it strongly that yes, it should be also one of the choice to start this patient as a GLP-1? Sanjay will again say the cost will be always high, but after once they become off patent, even off patent, it will be still high. But do you think that it should be a choice?
See, if suppose we presume that with DPP-4 inhibitors cannot be given at a particular stage, and if you have a GLP-1 option available, then certainly we can use this GLP-1 option also. But of course, we have to also understand the cost. As talking about EMPA versus DAPA side effects is almost similar. So I don't think there is any difference. But when you combine EMPA with LINA combination, a combination therapy in one pill, then the risk of having genital tract infection is much less when you give it separately, EMPA alone, so or DAPA alone. So it is better that if you're using this molecule, if you use a combination therapy or even otherwise separately, but then the two drugs also in the same patient, that might help in preventing genital tract infection. GLP-1 analog, yes, certainly is a good drug and can be used for glucose lowering efficacy. Renal benefits, of course, we have to still wait for. And cost is going to be the prohibiting factor here.
And also the side effects, particularly.
And of course, side effects of GLP-1 analog certainly is going to be.
Already having
yes.
nausea, anorexia, and other things.
Especially at low EGFRs at that
already
time.
low EGFR. They already
And by the time the tolerance becomes
a issue. They may have uremic symptom also. So you get.
And when
I had to stop in some patients, although it was officially we can allow it, but they could not tolerate it, even though they could tolerate it earlier.
And when we talk about SGLT2 inhibitors and CKD, it is basically proteinuric CKD. So those who have proteinuric CKD, there is definitely going to be a benefit. So irrespective of the EGFR.
So CKD, when we are talking in diabetes, here we are talking DKD only. So it means it is a proteinuric.
Yes, proteinuria.
We are not talking.
Yes.
The other reason why I was asking you that one side the GLP-1 also there is a issue of retina. And one patient with DKD, there is a increase, risk of that. But that is not been seen in a flow study. So what was the reason? I mean, it's such a confusing for the doctors that one side you are talking of that whenever you are using a GLP-1, you are worried of one side the fundus is to be examined more frequently, and other side you are talking that with the patient who is already established DKD with retinopathy, you want to put them on a benefit of cardiovascular and benefit of mortality or cardiovascular disease and further halting the progression of CKD, they should be put on semaglutide. So any idea or any comment on this?
Bansi, when we started writing Pioglitazone when it was launched, we used to monitor SGPT, SGLT every 2 months for 1 year, and then every 6 months, and then once in a year.
But then we started detecting it is decreasing actually.
That continued for a long period. Similarly, I feel something like this will go. By that time, we'll have a real world evidence, and then it will be shown that retinopathy deterioration is not a big issue. I feel that we have to wait and watch for such recommendation. Till that time, whatever data says, I feel we have to follow that.
It's more of neon rather than
yes, that's a more challenging. But that's again, we don't know the mechanism at present. That's again a challenge for us.
Yes.
So, if any other question, is AV team? If you can send me on my WhatsApp.
Just a quick comment, Bansi.
Yes, please.
Regarding type 1 and CKD, whether we can use it or not. If we can use it in non-diabetic people, why not in type 1 diabetes?
Yes. But because there is no randomized
control. But in a patient who is really vigilant, those patients who are susceptible to decay, better avoid.
Or
can I make a comment about that? See, if you look at all trials, right, they target type 2. It's not that these drugs are not effective in type 1, but the type 1 population is a very small population, and companies do not find it cost effective to do trials, large scale trials in type 1. So you never have data that is generated in type 1s, So if you look at across the board, different trials, they rarely recruit type 1 patients because of the population being very small, and as well as the fact that, it's not cost effective. But by extension of data from type 2, most people would tend to use it in type 1 because the pathophysiology would remain the same when it comes to end organ failures and the pathway to the end organ failures. So I don't think when we talk about, let's say, use of SGLT2s or GLP-1s in type 1s, that the data would say against it in any kind of a way, because there's no reason. I mean, why, if it's a diabetic pathway, then the pathway is going to remain the same. Is this a causality
of type 1 remains different in terms of etiology, but rest of the things remains more or less very similar. It's just that we haven't included them in the trials to emphatically say that we can use it in type 1 or not. So by an extension from type 2, I think it should be used in type 1, any of these drugs. I would strongly feel that way. Maybe Archana can, comment
No,
about
I
it.
agree with you, Sanjay, fully that what you are saying is perfectly right. But over a period of time, when real world evidence will be generated, we will able to have, more paper on these, in real world, if you had used, why don't you present it? That's the question, why we are asking that if some of us had used it. We have a type 1 diabetes conclave meeting, which is coming in first week of December. Why don't you present your real world evidence there? You can have your posters, papers, and we'll be very happy because they will be presented somewhere. So tomorrow evidence will be more generated in favor of type 1 also. That's the idea. Do we have, Ajay bhai, any other question? So the last question, do you see any role, which I don't see in my clinical practice, the low dose of SGLT2 with a 5 milligram of DAPA or 10 milligram of EMPA, still company keep on introducing these molecules. And then they introduce not only that, 5 milligram with sometimes sitagliptin also low dose or sitagliptin with 105 milligram. They create so much confusion. And then you have to keep on writing that this is your 10 by 500 or 25 by 500. So where exactly do you think this low dose? Because originally it was thought of that frail patient will need low dose of SGLT2. That was in initial period when SGLT2 was introduced. But later on, the data is showing all with the high dose, which is the normal dose, which is what optimal dose, low dose requirement is no more required. We had used in our clinical practice low dose because of the cost. So we used to give it half tablet. That was an idea because effectiveness is same, but not in frail patient. So where you find any of you, we start with Sanjay by Sunil, Sanjay, Pratap, Jetwani, Archana, everyone. In your clinical practice or any other definite indication for using low dose SGLT?
I don't think there is any big role here when it comes to low dose. Even
why
side
pharma
effects are
company are keep on introducing even after we are telling?
But yes,
I think
even this genitourinary tract infections are also almost similar when we have our own practical experience. So I don't think there's any role. But of course, that role was very valid when it comes to 100 milligram of Cana versus 300 milligram of Cana, when the price difference was too much. But here now, after this soft patent of all the gliflozins, I don't think there will be any role. Of course, as it can be individualized, we can start with 10 milligram and go up to 25 like EMPA. But certainly, as far as choice is concerned, there is no role of 5 milligram DAPA. No one, hardly any one of us have used this. But in EMPA, we have used 10 milligram and then we increase. But if you see the evidence is almost the similar outcomes.
Sanjeev bhai.
Yes, I think there is no role of 5 milligram of DAPA, but EMPA 10 milligram definitely has a role. It has equal cardiovascular protection as has 25 milligram. So both 10 and 25 are equally efficacious from glucose point of view. Only benefit of 10 milligram of EMPA is in a patient who is not overweight or underweight. 10 milligram will cause slightly less weight loss compared to 25 milligram. So there is some scope. Otherwise, I agree that 25 is the right dose. But with EMPA, we have evidence both with 10 and 25 milligram from cardiovascular end.
I think non-diabetic heart failure also it is EMPA 10 which is being used.
Yes.
So heart failure non-diabetic also EMPA 10
For
can be used.
diabetologists, I mean for cardiologists, it's fine for 10.
The EMPA was also with 10 and 25.
Yes, both.
10 and 25 both.
So I have only used the low dose sometimes when in down titration. So because sometimes what happens, patients do so well because it motivates, they lose weight, they lose all metabolic parameters, and
So they feel happy that from 25
well,
se
they
10
just
we
come
have
down
done
to a lower dose, and later on they ultimately end up with a maintenance low dose kind of thing.
Again, in
That's the
type
only
1
time I've
diabetes,
used.
better to use lower dose compared to higher dose.
Yes.
Otherwise,
For
it
type
would
1
reduce-
definitely
yes.
10
You
milligram.
could try that, yes.
Because 25 will reduce the insulin requirement significantly.
Sanjay
I
bhai,
have-
you want to add anything?
Yeah, so I have kind of used it in only one situations where you've got, heart failure with reduced ejection fraction with poor low output states, where they have probably, the blood pressures which are on the lower end. So as an introductory, so that they don't lower their blood pressures further, I do start with 5, but I up titrate to 10 very quickly if they're holding on the blood pressures pretty nicely. So, sometimes you may get a crash with all the other, agents that are going on, and you start an SGLT2. Sometimes you may get a problem, but that's the only perhaps situation where I may have used it with the low output states where I'm using 5 milligram. But then if the blood pressure holds on well, patient is well, I quickly up titrate to 10 milligram then.
So the last question is the patient who is in ICU already. Will you start the day one? Because ESC recommended already with the SGLT2 should be the choice before even this. But a known diabetic or first time detected diabetic, definitely they should be on SGLT2. Now question is with a patient who is acute coronary syndrome in ICU. Will you start the day one or will you allow patient to get settled with a diabetes part can be controlled with insulin and then you will add on second and third and with evidence. Again, I start with Dr. Sanjeev Phatak and then we end with Sanjeev.
Okay. So in acute condition, I do not have daring like DARE 19 trial to start in an acute hospitalized critically ill patient. I will not start.
But not critically. Suppose acute coronary, all patients are not critically.
So the current this Empagliflozin trial also failed to show any benefit in the acute setting.
So you will add on second
discharge,
or third or
yes.
fifth. Okay. At the time of discharge, not in the hospital setting. Okay. So in hospital role, probably in ICU, so for other condition also not there. For perioperative also not there. Once patient gets settled, like in a condition of hospital discharge, they should be started. Anybody differ? Otherwise,
I think any patient who gets hospitalized should be off SGLT.
Oh.
So with this, do we have any other question? So Ajay, bhai,
Right, sir.
I think everyone is very clear that when to use DAPA, when to use EMPA, when they will be using your low dose
Right,
10
sir.
milligram also. With these,
Right, sir.
I once again thank, and now I request Ajay bhai to give finally
Right,
vote of
sir.
thanks. But I am very much thankful to all panelists, all speakers, at the same time all the delegates who have registered and who have logged in for this meeting. Over to Ajay bhai for final vote of thanks.
Thank you. Thank you so much, sir. Just one point I wanted to highlight, sir, that we have a very deep on 7 parameter.
On video call.
On 7 parameter, we have compared both the drug, and we found that Empiga is nowhere inferior to innovator. That's the point I wanted to just tell at the concluding point. Thank you so much, sir. I thank all faculty members, Dr. Gupta, Dr. Sharda, Dr. Agrawal, sir, Bansi Sabu, sir, and Phatak, sir, and Jetwani, sir. Thank you so much. I also thank all delegates for joining the session. Interesting session. Acmedics is always there. In past also, we have supported all scientific activity. In future also, we will be there with you for all scientific activity. Thank you so much and good night to all of you. Thank you. Once again, thank you so much, sir.
Thank you.
Thank you. Good night. Good night, everyone. Thank
Good
you.
night, sir. Good night. Good night to everyone.
Good night.
Good night.
Recording stopped.